Hi everyone, welcome to researchmd.com. We got another great presentation. Today we're going to teach you all about evaluation of tremor. And again, my name is Pramil. Cheriyath. I'm a program director in internal medicine residency, transitional residency. I teach medical students, medical residents also. Director of research, I'm also an assistant professor of medicine, two major medical schools. So let's look at our definition. What is tremor? It's an involuntary. Before I talk about our subject, I want to make sure all our presentation will be done under 9 minutes. So watch it very carefully. Please repeat it. Okay, keep watching it again. That's the only way we can remember. There's no pointing in watching like a 45-minute presentation. You don't have much time. In life, time is very limited. So use it appropriately. Watch our presentation. Keep watching it again. Repetition is the key, my friend. All right, let's get into our topic today. What's the definition of tremor? Involuntary, rhythmic, oscillatory movement of the body part around one or more joints. And there are different types: action tremors, intention tremors, physiological tremors, essential tremors, isometric tremor, resting tremor, palatal tremor, orthostatic tremor, HOLMES tremor, dystonic tremor, myorrhemia, and functional tremor. Okay, action tremor, tremor that present voluntarily maintaining a position against gravity. Okay, it could be postural and orthostatic. And the other one is called also kinetic, during any voluntary movement, specific tasks, like so writing and golfing, that's kind of like a kinetic, okay? And then you have intention tremor, that is a kinetic tremor, worsens with approach when you approach the target, low frequency, like 2 to 8 megahertz. And then you have physiological tremor. This is an action tremor seen in the limbs and normally when unsupported, okay? Mainly maybe anxiety, fatigue, caffeine, and nicotine. Essential tremor. Isolated action tremor, it could be bilateral, usually in the upper limb. Tremor disappears with the walking. That's the main point, remember here. Okay, when the patient starts walking, the tremor disappears. While the resting tremor, which is enhanced by walking, okay? The resting tremor, it increases by walking, but essential tremor decreases with the walking. Remember that point. Isometric tremor, this is like when you try to squeeze something, or like a rigid stationary object, or making a fist, or squeezing an examiner's fingers, you start like shaking. That's called the isometric tremor. So, and the other one is the resting tremor. When talk about resting tremor, the tremor that occurs in the body that's not voluntarily activated and is completely supported against gravity. That's called resting. That's a term, resting tremor. Okay, example, you're resting on a sofa, right? It's completely supported against gravity. And mainly, two things you have to know is Parkinson's disease or drug-induced Parkinsonism. Sometimes you can have the pill rolling, like a thumb and index finger giving the pill rolling appearance. Wrist flexion and extension, and then forearm pronation, supination movements are common, okay? And the amplitude is diminished or stopped with the movement and increased with the mental stress. That's the common finding. May increase with walking. We talk about like the other tremor before, right? When you talk about the essential tremor, the tremor disappears with walking, while in the resting tremor, the main point is like increase with walking, okay? So it can affect any parts of the body, including lips, chin, jaw, legs, rarely head and neck or voice. Palatal tremor in the palate, rhythmic movement of soft palate is very rare. And then you have orthostatic tremor. That typically present with unsteadiness or standing still, which improves on walking, okay? May not be aware of the tremulous leg. And tremor may postural instability tend to worsen with the prolonged. If you're standing for a very long time, you can have like tremors in the leg. Fine tremors of the leg, usually palpable or visible while standing, and with a broad-based gait or poor tandem back may be detected. This tremor can affect other parts of the body if certain postures are maintained, like arms may be tremulous if the patient's leaning on the arm for a long time, it can become tremulous, okay? So primary orthostatic tremor is into type 1 is like a very pure, type 2 is like symptomatic associated with the cerebellar degeneration. The cis tremor diagnostic frequency around like 14 to 18 also, remember that. So HOLMES tremor is also known as rubral tremor, midbrain tremor, or thalamic tremor, myorrhemia, and Benedict syndrome. It arises from the structural disorders including stroke, vascular malformation, or tumors, okay? So it's a pathological tremor again. Rubral tremor, midbrain tremor, thalamic tremor, or Benedict syndrome. Now, another one we have to know about the cerebellar tremor, okay? It's a kinetic tremor considered characteristic of cerebellar pathology, and slow oscillation of the arm about the shoulders, legs, about the hips, particularly striking when a patient is standing, and I mean, the main thing, it accompanied by other cerebellar signs, right? Finger to nose test, dysarthria, diplopia, all those kind of things. Sometimes it can be seen with the patient multiple sclerosis, mass lesion, vascular disease, or hereditary or acquired cerebellar degeneration, spinocerebellar ataxia. Multiple sclerosis tremor, action tremors, again, arms 55%, and usually you can have this multiple sclerosis for 15 or 20, around 13 years or later, this symptoms start developing. Also with dysarthria, dysmetria, and walking time affected. Dystonic tremor is also, there's always going to be dystonia associated with it. Functional tremor, this is what psychogenic, people making it up. Distractibility, frequency entrainment, adopts frequency set by the examiner. Antagonistic muscle coactivation, variable in amplitude and frequencies there. And there's always medication. We take so many drugs now these days, right? All of this, a nebulizer treatment with albuterol, salmeterol is very common. Amiodarone, tricyclic antidepressant, SSRI, thyroxine, lithium valproate, immunosuppressants, and all of this can cause medication tremor. So how do you evaluate? We put this nice picture. First thing you have to know, tremor, is this resting tremor? If it is resting tremor, always kind of think about Parkinson's disease. So if it is an action tremor, then you just if tremor present mainly with the movement rather than with the maintained posture against gravity, if it is, just think about kinetic tremor. And if it is not, think about tremor present while maintaining posture against gravity. Then you have to think about the postural tremor, orthostatic tremor, and all that. And if it is not, then you look at this, an isometric tremor, because you're trying to squeeze something and all that. So follow this pattern, when you come with a diagnosis. So investigation, you need to do regular lab work to make sure all our electrolytes are okay. LFTs are important because, Wilson's disease, the ceruloplasmin, copper study, thyroid study, MRI of the brain, EMG, genetic studies, depends upon what is our, suspicion. In treatment, mainly symptomatic and depends upon the cause. I mean, each cause have a different treatment. We just kind of put essential tremors. You can use propranolol, primidone, topiramate, gabapentin, alprazolam, and clonazepam. And there is a botulinum toxin in dystonic tremors. Botulinum toxin can be used. Thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel. Thank you.